Good afternoon, ladies and gentlemen. The topic of this lecture is anatomy of skin lesions. In this lecture, I am going to discuss various terminologies that are used to describe skin lesions. These terminologies will help you in your short cases and describing the lesions during your day-to-day practice. I am going to give some illustrations and examples and pictures which correspond to the terminologies that are being used in the lecture. I have given a similar lecture some time back in these series of lectures. You can consider this as a continuation of that lecture. So let's proceed for today's lecture. Morphology. Morphology of a skin lesion is the form or structure of an individual skin lesion. So the skin lesions may be flat, elevated above the plane of the skin, or depressed below the plane of skin. They may be skin colored or red, pink, violaceous, brown, black, gray, blue, orange, or yellow. So they can be of different shapes. They can be of different colors. They can be of different consistency. For example, they can be soft, firm, hard, fluctuant, or sclerosed, scarred, or board-like. Lesions can have altered temperature. They can be hotter or cooler. And lesions can be mobile or immobile. So all these terms are used to describe a particular skin lesion. That is its shape, its color, its consistency, its temperature, and whether it's mobile or immobile. So these are the basic terms you all know: macule and a patch. Macule is just a small patch of skin less than 1 centimeter that just has an alteration in color, but it should not be elevated from the normal skin. And patch is a bigger macule that is more than 1 centimeter in size, again, an area of color change. You see in these pictures, this is vitiligo, in which there are patches of depigmented skin, melasma, patches of pigmented skin, facial erythemas, and lentigo, in which mainly the skin is just characterized by an alteration in skin color. Then papule, you all know, is an elevated, solid, palpable lesion that is less than 1 centimeter in diameter. They can be solitary or multiple. Usually they are multiple, and papules may have different shapes. For example, it may be acuminate, which is pointed, dome-shaped with round top, filiform, thread-like, flat top papules, oval or round, pedunculated with a stalk, sessile without a stalk, umbilicated with a central depression, and verrucous papules giving a warty look. So I will show pictures of all these kind of papules. But before starting, let's see what is a nodule is. Nodule is an elevated solid palpable lesion that is more than 1 centimeter in size, and it is different from a plaque. That nodule has a round or a dome-shaped surface, and plaque usually have a flat surface. So these are small pinpoint papules. Some of them are dome-shaped, some are flatter. These are a few umbilicated papules. You can see the papules with central umbilication. This is a characteristic lesion of molluscum contagiosum. Then you can see here, these are acuminate. These are acuminate papules, which are slightly raised and pointed. And this is a filiform wart, finger-like projections. are seen. It's a filiform papule or a filiform wart. This is a dome-shaped papule. Multiple plain top papules, plain warts, you can see day-to-day practice. Then this is a pedunculated papule or a nodule, soft in consistency, a neurofibroma. So here you can see a patient of neurofibroma in which there are few soft nodules that are attached without a small stalk. So these lesions are called as sessile lesions. And the lesion which have a stalk, they are called as pedunculated lesions. Now these are the accumulated papules or plaque with a warty surface, with a thick, rough surface. These are called as the warty papules. They are confluent to form a plaque. Then cysts. Cysts are usually papules or nodules that contain fluid or semi-fluid material, so they are fluctuant and soft. So sometimes a punctum is seen in the center, which is usually seen in epidermoid or epidermal inclusion cysts, not seen in other cysts. Poikiloderma is a skin condition in which there is a variegated mixed pallor, telangiectasia, and pigmentation. Let's see the cysts. This is a typical epidermal inclusion cyst with a punctum. Then this is a pilar cyst seen on the scalp. These are Steatocystoma multiplex, multiple sebaceous cysts seen on the trunk and limbs. A very fluid containing cyst seen close to the eye margin, and this is a hydrocystoma. This is a picture of poikiloderma, which is characterized by atrophy, altered pigmentation, and telangiectasias. Then a plaque. Plaque is a circumscribed palpable lesion that is more than 1 centimeter in diameter and usually have a flattish surface. Plaque may result from coalescence of papules. Most plaques are elevated, but plaques can also be thicker areas without being visibly raised above the skin. So such plaques can be called as the infiltrated plaques. They may have well-defined or ill-defined borders. The name plaque is derived from the French word for a plate. And plaques may be annular, ring-shaped, arcuate, half-moon, polygonal, multiple ring-shaped, polymorphic, various shape, and serpiginous, snake-like. So you can see this is an annular plaque, a ring-shaped plaque with central atrophy, then an arcuate plaque, which is half ring-like, arch-like. Then these are polycyclic, multiple ring-shaped lesions. This is a serpiginous plaque in a form of a snake, lava migrans. Then sometimes the plaques are of variable shape. You can see individual papules which are raised and pointed. Some are confluent, some are annular, arcuate. So there are different shapes in this appearance. Then another type of skin lesions are those which contain fluid. So the small fluid-filled lesion is called as a vesicle, usually less than 1 centimeter in diameter. It can contain clear fluid or serous fluid or hemorrhagic fluid, can be single or can be multiple. And bulla is a lesion again containing fluid, but it should be larger than 1 centimeter. Again, it can contain clear, serous, or hemorrhagic fluid. Pustule is a small, less than 1 centimeter lesion that contain pus. And on histology, it will be filled with neutrophils. And you know that all the pustules are not infected. There are many diseases which have non-infective pustules. An abscess is a large lesion that contain a pus, also known as a fruncle. So these are the small vesicles with surrounding erythema, commonly seen as chicken pox. Then this is a blistering disorder with large, more than 1 centimeter fluid-filled bulli or blisters. These are the hemorrhagic bulli and seen on the background of vasculitis. So these bulli contain blood. This is an example of pustules. Multiple small pustules are seen in this picture. Gram-negative folliculitis. Then this is a fruncle or an abscess with a punctum, and it is raised, it is hot, and it is indurated and painful. Wheal, which is also spelled as W-H-E-A-L, wheal, which is a transient elevation of skin due to dermal edema. Often it's pale centrally with erythematous rim without any surface change because it is only because of dermal edema. So it's seen in urticaria or urticaria-like lesions. So you can see these urticarial wheals. This is dermographism. These are all transitory. They subside within few hours. Then the skin lesions, it's important to note the surface changes in the skin lesions. And the surface changes indicate the epidermal changes. And if there is no surface change and the surface of a lesion is normal or smooth, it means that the pathological process is not involving the epidermis, but rather it is in dermis or subcutaneous fat. So scaling or hyperkeratosis, these are two different terms. Scaling usually indicates parakeratosis, and hyperkeratosis indicates that the stratum corneum is thickened. And clinically, these scaly conditions appear as desquamation. They can be psoriasiform scales. They can be petrosiform scales. The lesion can be lichenoid, in which there are no true scales, but rather Wickham striae are seen. And if you try to remove the scales by means of a tongue depressor, you won't be able to do it. Then keratotic scales, usually seen in keratotic disorders, keratodermas. Exfoliation is peeling of the skin. Maceration is moist peeling of the skin. And verrucous lesions are warty lesions. So you can see in this picture, there is desquamation or exfoliation of the skin. Keratolysis exfoliativa, a benign condition, usually seen with change of seasons. Then these are thick silvery scales on background of indurated and salmon-pink plaques, typical of psoriasis. Then this is petrosiform scale, which are soft and are seen at the periphery, lagging behind the erythematous ring. Then these are the mica-like scales of PLC, and you can remove the scale in total. So this is another form of scaling. Then these are the tin tack scales, which are seen in DLE. If you remove the scales, there will be pointed tips underneath the scale surface. This is the follicular scaling, follicular psoriasis or follicular eczema. The scales are seen on the hair follicles. This is a hyperkeratotic lesion. Here, there's no scaling, rather there is increased thickening of stratum corneum. So this is focal keratoderma. This is a lichenoid lesion with the Wickham striae, which look like scales, but if you try to remove these scales by scratching, they will not be removed because this is because of hypergranulosis rather than hyperkeratosis. So this is erosions as well as maceration. So the skin is eroded here as well as macerated. Then the distribution of skin lesions. Distribution refers to how the skin lesions are scattered or spread out. Skin lesions may be isolated, solitary or single or multiple. This is important. Localization of multiple lesions in certain region help in diagnosis, as skin disease tend to have a characteristic distribution. What is the extent of eruption and its pattern? So the lesions can have an acral distribution. That means it is related or affecting the distal extremities. For example, the ear, finger, toes, nose, penis, and nipples. Blaschkoid lines following the roughly linear segmental pattern described by Blaschko. Many birthmarks appear to be distributed within these segments. Then dermatomal lesions are confined to one or more segment of the skin, innervated by a single spinal nerve or dermatomes. Aggregate lesions means gathered or loosely clustered lesions. Grouped, closely clustered lesions. Confluent lesions, papules so close to each other that they merge into a big lesion. Satellite lesions are the small lesions around a main lesion. So the lesion can have an acral distribution. You can see the pinpoint hemorrhagic blisters or lesions on the toes and fingers, commonly seen in COVID patients, we call as COVID toes. These are basically perniotic lesions. Then these are the Blaschkoid lesions. You can see the verrucous epidermal nevus seen in the distribution of Blaschko lines. Then dermatomal lesion, herpes zoster, usually confined to one or maybe two nerves in a dermatomal pattern, never cross the midline. Aggmenate lesions. The lesions are closely clustered together, so acne aggmenata. Closely clustered together, these are the group lesions. Then confluent lesions, the papules are so closely set that they merge into each other to form a bigger plaque. These are the satellite lesions which are seen surrounding the main lesions, the candidiasis with the satellite lesions. Lesions can be distributed on extensors. This may give a clue and may be distributed to flexures, skin folds like back of knees, armpits, elbow creases, and groins. Lesions can be follicular. Lesion can be generalized, that is distributed over most of the body surface area, and widespread or erythroderma involving more than 90% of the body. Herpetiform means the vesicles in an annular distribution. Cobnerization, new lesions of skin disease such as psoriasis at the site of trauma or scratch marks. So extensive distribution of lesions are important. For example, these are the papulovesicles seen on elbows. So this is a common presentation of dermatitis herpetiformis. Similarly, the flexural lesions usually we see in adult atopic dermatitis or airborne dermatitis. Then follicular lesions. There are many follicular dermatoses in which the lesions are mainly follicular, can be follicular eczema, can be lichen planopilaris, can be follicular psoriasis. So the lesions are primarily seen on the follicles. The lesion is involving more than 90% of the body, and body is erythematous and scaly. So this is erythroderma. So the lesions can be herpetiform, that is the vesicle or blisters arranged in annular configuration. This is cobnerization. You can see the psoriatic lesions seen in the area of scratching or trauma, also seen in warts and lichen planus. Lesions may have a photosensitive distribution, that is, they are involving those areas which are photosensitive. There are lesions which are restricted to head and neck region. For example, it spares the eyelids, depth of wrinkles, furrows, again seen in photosensitivity, and involving the V-shaped area of the neck. Lesions can involve the hands. Sometimes they spare the web, sometimes it involves the webs like in scabies. Then can be restricted to feet, can be restricted to lower legs or shin areas. There are lesions which are only present on dorsal ventral surface of the trunk. So the lesion can be restricted only to hands. These are the Gottron papules seen in dermatomyositis. This is a photosensitive distributed lesions, mainly seen on the neck area and is sparing the hidden areas or the areas covered by clothing. Then lesions typically seen on the shin, hot, symmetrically distributed nodular lesions. So this is erythema nodosum. And you can see these crusted papules and plaques on the chest. And this is acne conglobata. Lesions in acral distribution. This is Raynaud's phenomena seen mainly on the fingers. Then lesions can be seen on pressure areas, and like top of the ears when sleeping, buttocks when sitting, or in a bed-bound patient, heels in again and comatose or bed-bound patient. The lesions can be seen in a seborrheic distribution that is related to those areas in which there is abnormal increased sebum secretion, producing an oily appearance of the skin and formation of greasy scale. So this is a pressure sore. This is a phase 1. Still, this is an erythema, no ulceration, and usually seen in patients who are dependent on others. And this is acanthoma fissuratum, which is seen due to contact of a spectacle frame. And this is chondrodermatitis helicis, usually seen when the patient is using some gadgetries on the ear or sleeping on a specific posture resulting due to trauma. Then a seborrheic distribution of rash seen mainly in seborrheic eczema. So diarrheal disease in which you can see these greasy papules again in the seborrheic distribution. Langerhans cholestasis again seen in seborrheic distribution. The lesions are little purpuric. Then lesions can be symmetrical, involving both sides, or unilateral. Usually, the symmetrical lesions are those lesions which are genetic or idiopathic, and the unilateral lesions are due to infections. So you can see here this symmetrical reticulate pattern, and this is livido reticularis or erythema abigni here, and which both sides are symmetrically involved. And here, one of the leg is swollen, erythematous, edematous, and painful and hot. So this is cellulitis, which involves one leg and does not involve the other one. Then configuration of the lesion or shape of the lesion. Configuration refers to shape or outline of skin lesions. Skin lesions are often grouped. We have shown you some pictures of the group lesions. The pattern or shape may help in diagnosis of many skin conditions that have a characteristic configuration. So lesions can be nummular or coin-shaped, also known as discoid, can be linear. For example, Koebner phenomena is an example of Neelian lesion. Then target lesions. Concentric ring-like dartboard is also known as iris. Lesions are target lesions typically seen in erythema multiforme. Gyrate lesions are the rash that appear in whirling in a circles, multiple rings, one in another. Annular lesions have already seen and discussed. So you can see the discoid lesions, disc-shaped or coin-shaped lesions, usually symmetrically distributed on both sides. This is nummular eczema. Then linear, these are stria gravidarum or stria distensi. The linear lesions, atrophic linear lesions, they are depressed from the surface. Then the targetoid lesions we see in erythema multiforme. There is a pallor and central erythema. So pallor outside and erythema inside. Sometimes you can see vesicle bulla in the middle. Gyrate lesions, erythema gyratum repens. You multiple ring shape rings seen concentrically around each other. Then sometimes the color of lesion, or many times color of lesion will also throw some light on its etiology. Keratinoderma is yellow or orange skin color due to excessive circulating beta carotene. The vitamin, a precursor derivative derived from yellow orange colored vegetables and fruit, and tend to be pronounced on palm and soles and does not affect sclera. Hyperpigmentation is just darkening of the skin. Hyperpigmentation, light or depigmentation is complete loss of melanin. Leukoderma, white skin, also known as achromia. Then infarcts can black necrotic areas. So you can see this carotenoderma, in which there is typical orangish, yellowish hue seen on palms as well as on the face. Then these are depigmented lesions. This is hyperpigmented lesion, erythematous lesions. So different colors of the lesions, necrotic lesions seen in DIC or purpura fulminans. Patient may be jaundiced, so skin will take yellow color, and even sclera will be jaundiced due to biliary or liver disease. Skin can be erythematous. It can be erythroderma, telangiectatic with prominent cutaneous vessels, or purpuric, bleeding into the skin, either petechiae. Petechiae are the small red, purple, or brown spots, and ecchymoses are large, bruise-like lesions. The typical feature of purpura is that the purpura, since it contains blood, so on pressure or blanching or diascopy, they will not go, the color will not go. So they will be non-blanchable. So they can be palpable in vasculitis and non-palpable in simple purpuric diseases. So petechiae are small size purpuras and ecchymoses are large bruises. So this is jaundice, typical yellow discoloration, also seen on in the sclera. Then erythema on the face. You can see erythema with telangiectasias, typical erythemotelangiectatic rosacea. Then purpuric lesions, cutaneous amyloidosis or systemic amyloidosis. So purpuric lesions can be seen in various kinds of purpuras and vasculitis, clotting or coagulation defects. Then lastly, the secondary changes. Secondary changes are those changes which are not the diagnostic, which are not diagnostic of any particular disease, but are produced as a result of various signs and symptoms of the disease or complaints of the disease. Such secondary changes sometimes help in making the diagnosis. So the secondary changes include lichenification. Lichenification is thickening of the skin caused by chronic rubbing, not acute rubbing, and results in palpably thickened skin with increase in skin marking and scales, thick scales. It occurs in chronic atopic eczema and lichen simplex. Then crusting. Crusting is an acute lesion result from plasma exudating through the eroded epidermis. It can be yellow crust or brown crust or even bloody crust. Dystrophy. Degeneration or abnormal formation of the skin, often used to refer the nail diseases. Then excoriations are loss of epidermis and portion of dermis due to scratching. Usually it is of linear distribution or can be punctate. Then erosions, a sore due to superficial or partial destruction of a skin surface. So this is a typical case of lichen simplex chronicus. The skin is thickened and the skin markings are prominent due to chronic scratching. This is a crusting. Yellowish or brownish crust are seen on the lesion, acute eczema. Then dystrophy, the nail surface is destroyed with pitting, with ridging, with color change and thinning of the nail plate. So everything is destroyed. It's not a normal nail, so it's called as nail dystrophy, 20 nail dystrophy. Superficial erosion. Erosion is loss of epidermis, but not but the whole epidermis is not lost. Some portion of epidermis is left. So usually the erosion heal with pigmentation, hypo or hyper, but not with scarring. So you can see here the linear excoriations, very itchy condition. You can see fissures, which are split cracks and erosions and narrow ulceration. You can see fungating lesions that refer to large malignant tumors that erupts like a mushroom or a fungus. Ulcers, full thickness loss of epidermis plus at least a portion of the dermis that may extend into subcutaneous tissue. Ulcer usually heal with a scar. Then granulation tissue, it is made of mass of new capillaries and fibrous tissue usually seen in a healing wound. Sometimes excessive granulation tissue hampers in wound healing, so we have to remove that granulation tissue for proper healing. Then granulomatous lesions are usually infiltrated thick lesions, which we commonly seen in many granulomatous infections like leishmaniasis, lupus vulgaris, deep mycosis. Hypertrophic lesions are raised thick lesions It's usually scars due to excessive collagen proliferation. You can see this fissured heel here in this picture. A large fungating squamous cell carcinoma. Then a big ulcer, pyoderma gangrenosum. And you can see the granulation tissue here. This is a healthy granulation tissue. It is a healing lesion. Again, a healthy granulation tissue here. The ulcer is going to be going to heal very soon. Then this is a hypertrophic lichen planus, usually an itchy condition, and lesions are quite thick. So that ends this lecture. It was a basic lecture, and I hope it will be helpful to young trainees, new trainees. And if you link this lecture with my previous lecture on the similar topic, that is the introduction of skin lesions, you will benefit more. So thank you very much, and for listening to the lecture and liking the lectures. And see you very soon with another edition of my lecture. Good night and have a good day. Good night and have a good week. Bye-bye.